spectrum of information we get out of these data is huge. It drives everything from our contract negotiations with the hospital, because we're now able to say, you know, this is your real utilization. And we can make arguments one way or the other to improve other utilizations, compensation for inefficiencies, and all those kind of things. So it's a very solid argument when you say, well, utilization here in this area is only 65%. That's not good enough, you know. And so you have really strong arguments in your negotiations that you can use this kind of things. We use it for internal quality improvement. We have our own QA committee that looks at cases that had any complications. So once a month we have a report that's printed for our chairman of the QA committee, and he looks at every complication that happened in the last month, and so that gives us a good feedback about the quality of care. And we sometimes use it also for almost daily operations. An example would be we have particular surgeons that, you know, do nose surgery. We looked at their surgeons, we looked at the time that those patients spend on recovery, and we went to the hospital and said, you know, it would make more sense to have these surgeons get the morning shifts instead of the afternoon shifts, because then the patients can leave in the afternoon and they're not delaying the PACU closure. So, you know, it's this sort of daily operational things where people always say, oh, you know, this takes too long, and, you know, but this is all anecdotal. And it's very hard to get hard numbers to really go and prove this.